If I quickly first of all go through the admin stuff. The meeting this evening will be live streamed to the public. A recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. Remote participants joining using Teams, use the hands up icon on your screen for questions and comments. Please turn your camera and microphone on when speaking and off when finished. Would members and officers please remember to switch their microphone on when speaking and off when they have finished speaking and speak directly into the microphone. Would in-person attendees please switch off mobile phones or place on silent mode? Thank you. Okay. Let's start off with apologies for absence.
Apologies from Councillor Isles.
Thank you. I think before we go any further, we should go around and let everyone introduce themselves so we know who everyone is. Starting, Councillor Arndt.
Suzanne, Councillor for Party.
Good evening, Councillor Aziz Ambia from Birmingham. Thank you.
Director of Adult Social Care. I'm Kate Robertson. I'm Corporate Director for Population Wellbeing.
I'm Michelle Bradley, Director for Health, Mental Health and Learning Disability Services.
I'm Paul Teasley. I'm the Medical Director at Bedfordshire Hospitals.
Kathy Jones. I'm the Deputy Chief Exec and Chief Operating Officer at Bedfordshire Hospitals.
Good evening, Hannah Lees, Head of Commissioning, Adult Social Care, Luton Council.
And Stephen Farley, Senior Integrated Commissioning Manager at Luton Borough Council. Adult Social Care.
Luton.
I'm Francis Steele, member for Lee Grove.
Hi, Councillor Bacon, Central Ward Council.
And I'm Councillor Richard Underwood. Okay, the minutes of the meeting on the 17th of February 2026, those of you who were there, are they a fair and accurate reflection of the proceedings of that meeting? Thank you. Any disclosures of interest? Councillor Bacon?
Thank you, Chair. I'd like to disclose a personal interest. I'm a public governor for East London Foundation Trust, which is an agenda item. Sorry, I'm just trying to find the agenda item 9.
Okay, that's noted. Any urgent business?
None, Chair.
References from committees and other bodies?
Again, none, Chair.
Thank you. I have a couple of things to update the meeting on. On March the 13th, Director of Public Health and myself attended the Mount Vernon Cancer Centre Relocation Scrutiny Group meeting in Stevenage. That meeting was an update on the consultation exercise undertaken by NHS England that finished at the end of March. Hopefully you'll recall that our last meeting of this committee, we passed a motion stating that we would support option C of the relocation plan, option C, that's in addition to the relocation of the cancer centre to Watford General Hospital, it also includes locating a satellite radiotherapy unit at the L&D. And subsequent to that, we have sent a letter to NHS England detailing why we believe that option C should be adopted. So that letter laid out the advantage of locating the units at the L&D in terms of resolving health inequalities, location, and travel times, and provision of a skilled and resilient workforce. That letter was signed by the leader of the council and myself. The other item to let you know about is that since the last meeting, I've had a number of meetings and discussions with Democratic Services and public health officers about the future work of this group, centering around taking a more in-depth exploration of specific topics in public health. the intention is that whoever is on this group in the new municipal year will take that work forward. If you have any questions about any of that, then please let me know. Okay. If we go on to the first report of the evening, paediatric audiology at the L&D.
Thank you very much, Chair. If I may briefly introduce the report, and then I'll hand over to Paul to give a little bit more background on the clinical status of the incident at the moment. The report describes the circumstances that led to us declaring a business continuity and patient safety incident at the Luton and Dunstable Hospital. That relates to the care of a cohort of children under our paediatric audiology service. Through our usual governance and safety reporting mechanisms, we identified a small cluster of young children who appeared to have had suboptimal outcomes following care under the paediatric audiology service. That was triggered from new staff coming into the service, which had been struggling to recruit staff historically for many years. Paediatric audiology is a really highly specialist discipline, and there is a national shortage of qualified staff. So the service was quite fragile and had been struggling for some time. The new staff coming into the service reviewed children as part of their routine care and identified that there was the potential that harm had been caused by suboptimal management. So at that point, we took the decision to undertake a recall review of a number of children where we identified that there may have been suboptimal care provided. This report was submitted with the data accurate at the point of writing. Perhaps if I could just hand over to Paul now to discuss where we are today.
Thank you. Good evening, everybody. So as part of this incident, we've also put it through our patient safety incident response framework, which is our clinical governance process. And we declared that as a patient safety incident investigation. So that will look at all the contextual factors of this, and we'll have a final report. In terms of the active management of these children, as Kathy has alluded to, we've now got the right number of staff in place. We are recalling all of those children for a harm review. These reviews are very time consuming and may take 3 to 4 hours per child, depending on the age. And within that review, we're grading the level of harm. Now, in order to ensure that we're grading that level of harm correctly, we are benchmarking this against region. And so within our Central East Integrated Care Board, so that is obviously Cambridgeshire and Peterborough, BLMK and Hertfordshire, there is an incident review panel that will actually effectively cross-check and make sure we've graded that harm correctly, because there are concerns in those other areas as well. So it is bringing all of those subject matter experts together. We run a weekly incident review group, and that is attended by the Integrated Care Board, as well as a regional chief scientific officer who is a paediatric audiologist by background. So that we've got the right external scrutiny of this. The paper you have in front of you shows that we have identified 109 children that may be affected. Now that number has increased to 112 because we've had a couple of 2 children that have had we've identified and not been followed up, and one that came for a hearing aid repair. We have undertaken 40 full harm reviews to date. And we've got the breakdown of the grading of those reviews. So of those, obviously the most concerning ones are that 9 are graded as severe and 14 is graded as moderate harm. And on page 3 of the paper, we've defined what we mean by severe harm and what we mean by moderate harm. Those with moderate harm, it's very likely that with appropriate intervention and ensuring they have the correct hearing aids, and that these are regularly followed up, and with speech and language therapy, that you will achieve a recovery in that child's speech and development. Obviously, with the severe harm children, that recovery may be less effective. Now, these are quite a complex group of children. They often have other developmental issues and other social factors, so it isn't as straightforward as a single issue. But we'll be bringing all of that information together as we report it through our incident investigation. We've given you the breakdown of the number of children that belong to Luton Borough within this paper as well, and graded the level of harm. What I don't know of those 3 additional children, I don't know the borough breakdown of those 3 at this stage. I think that is probably the summary where we're at the harm review. But as I say, we've got really good engagement from our integrated care board and from the region. So we are working this as really one team to try and deliver sort of any remedial care for these children, while at the same time, of course, treating any new children referred to the service. So we have to do both of these things at the same time.
If I may, Chair, if I may, Chair, one final point, and that's that we have been working with our colleagues in Cambridgeshire Community Services, now East of England Community Services, and have identified the opportunity to bring in additional speech and language therapy for the children affected. So we will be funding CCS to provide an additional experienced speech and language therapist to provide specific support to the children who've been identified as part of this process. Very happy to take any questions.
Okay, thank you very much. Questions? Councillor Begum, then Councillor Ahmed.
Thank you, Chair. Thank you for the report. I have a question on 4 questions, so I'll ask them one at a time. I got told off by my colleague today. Okay, so the report says it shows that these issues have been built up for over many years due to staffing shortages, recruitment issues, and so on. But how did we get here? Why did this take? How did this get so far for us to realize, okay, something is going on here? I know in the report you said one of the new specialists recognized it, but how did it get so far without being noticed?
Thank you. And I think there are a combination of factors. The first is that members may be aware that paediatric audiology services nationally have been subject to review. That was triggered by something called the Lothian report, which identified a pattern of underdiagnosis of children with profound hearing impairment, but also recognising the national fragility of the workforce. So for many years at the hospital, the team have been running with one senior member of staff supported by another individual, and have been working to make sure that that they manage the children with the capacity that's available to them. As we explained, we've been trying successively to recruit to specialist paediatric audiologists, and a peer review took place for every service in the East of England region across the course of 2025. That identified at that point that they were concerned about the fragility of the service, but no harm was identified to children as part of that peer review assessment. What subsequently has happened is that new staff joining the team have been open and transparent about the risk of harm because of delayed follow-up. And so what we're trying to do now is a process where we're reviewing all of that cohort of children to really understand whether there were missed opportunities in the care that we've been delivering. Because we're still in the middle of that process, it's hard to understand fully where we will arrive on that.
Yeah, and obviously when we complete our big incident investigation report, that will sort of really give us the root causes of this, and so we will have a final answer as to how this happened.
Okay, I'm sorry, that brought up a supplementary question in my head. Surely there may have been parents of children who have been having issues with hearing and all other issues. I'm sure they would have gone to GPs, and there would have been huge number of young people? Surely that should have been a red mark somewhere. So I'm trying to say, isn't there, before the inspection, wasn't there no one noticing that there was something wrong here?
I think that the answer to that will come through fully in the review, but as Paul indicated, the complexity of the children affected means that it would be potentially quite difficult to understand whether the impact of any developmental delay was because of challenges with hearing and speech and language development, or whether it was other clinical or social factors that were resulting in that. So it's not quite as straightforward as, perhaps where there was a single health issue that might have been spotted by other professionals who were interacting with these young people, or by teachers or parents or GPs.
Thank you. We'll wait for the report and see what happens. The second one is about the out of 109 children that are identified, 85 are from Luton. Do we know why that is? Why is the impact in Luton higher compared to other places?
Sorry.
So this is the Luton and Dunstable service. So effectively, just by the location of the hospital, the majority of children will be from Luton Borough and the smaller proportion from central Bedfordshire.
Thank you. So this is around, do we know if children from certain communities or backgrounds in Luton are more affected than others? So I'm thinking around health inequalities.
And I don't think we have all of that information yet, but that will come out in all of the harm reviews and all of the contextual factors. So is it certain communities? So we will get the answer to that question.
So I know you kind of partly answered it while you were giving your presentation. So those children who have experienced severe harm, what long-term support will be put in place for them and their family? I know you mentioned speech therapy. What other things are in the plan, or have you started them already?
So of the harm reviews undertaken, if we've identified harm, then of course any remedial actions we put into place. So they will have an appropriate follow-up for their audiology, for their hearing services. We obviously involve the National Deaf Children's Society in that work, and also ensure that any appropriate referrals for speech and language therapy. So as well as the capturing the harm from the reviews, you are treating those children as well as you identify the issues. You're not waiting for completion of that review.
Yeah. Thank you, Chair.
Thank you. Councillor Ahmed.
Thank you, Chair. Most of the questions my colleague have already asked for. Thank you for the report and the update. This is clearly a very serious issue, particularly given the number of children affected and the potential long-term effect on speech, communication, and development. Just so what assurance can you give tonight that no child currently under care is at risk of experiencing similar delays in the future?
So I think this is all about the workforce. I think we've been very lucky to recruit a new audiologist in September 2025 who actually identified this issue. We've got 2 other members of staff that we've recruited and some other mutual aid support. So I think we've got probably one of the strongest workforce positions across the region in terms of our service. So going forwards, any new children, we're quite confident that they will be managed correctly. In terms of those children with a severe harm, which you mentioned, what we have done with those reviews is try and prioritise the younger children for those initial reviews to ensure that you've got the maximum opportunity to try and correct any issues. So we think we've probably identified most of the severe harm so far. Now, I can't say that for certainty, but by focusing initially on those under 5-year-old children and under the under 7s, if there is an opportunity to improve, then we will take that.
I think if I may just add to Paul's response, I think we do need to be honest that the capacity taken to review these children and put in additional and further clinical management plans is really significant. Often these children require 2 senior specialist testers. It's quite a complicated process to test, refit, and adjust the hearing aids, and particularly when that's combined with perhaps some other developmental or behavioural challenges. So the service for the capacity is still under significant pressure. Our new waiting times for new referrals are clinically triaged, and we are managing the most urgent referrals as a priority and making sure that we're balancing that with the need to make sure that we're delivering these reviews and supporting these young people. And unfortunately, that is a picture that's repeated in units around the region and indeed nationally. We have done everything available to us to bring in as much mutual aid as we can, and our efforts are in making sure that that team's supported to really optimize the clinical care delivery, and we're trying to take the burden of administration and other things away from them to make sure that we can do this as quickly and as well as we can. But I think in terms of full assurance, we are still not able to guarantee that we're seeing children within the national best practice timescales. We're using then clinical prioritisation to make sure that harm doesn't happen as a result.
What is the current staffing shortfall in pediatric audiology, and by when do you expect this gap to be fully resolved?
So that's quite a moving picture, but across the two hospitals, I think we are now fully recruited at Luton, but with only one gap at the Bedford Hospital site. And it's important to note that the Bedford Hospital service has not had the same level of challenge historically as Luton. But the additional workload of doing these re-reviews, retesting and recalibration clearly means that we are still somewhat under capacity. We remain out to recruitment for senior paediatric audiologists at a variety of grades and levels, and we will continue to use mutual aid at every opportunity to provide additional sessions to us. But the picture is, I might use the word, unrecognisable from where we were a year ago in terms of the staffing resilience of this service. So really good progress has been made.
Thank you.
Thank you. Councillor Hussain.
Can I ask you, how long is this problem has gone on in terms of your recruitment shortage? How many years? What are we talking about? How long have you the contract?
So this is part of our core NHS contract, and the service has been provided at the Luton and Dunstable Hospital for as long as I've worked there, and that's 20 years next year. The look back, the case reviews that we've done go back 5 years. And prior to that, there was additional staffing and support, and demand for services was lower. So the children that have been identified in the at-risk cohort, the 109, that goes back 5 years, which is the concerns around staffing.
The reason I'm asking you that, because in terms of the harm, yeah, and will that child at the end of the day will recover from it, or is that permanent damage because the treatment was not given in time?
I think that depends on the grade of harm. I'm quite confident with those of moderate harm, there'll be an opportunity to improve their speech and language. I think with severe harm, I think that question is unknown at this stage, but clearly any remedial action that can be taken will be taken, but we will not know the end state at this stage.
Serious concern is that the child gets a one chance. There is no chance, two chances. The same is with children's services. When a harm is done to the child, there's no reverse, is it? So that's what I've got to take very seriously. If the problem has gone on for considerable time, you as a statutory agency have a very serious duty of care. You know?
I think, as we know, the cases were picked up in the late autumn, going into November time, as we immediately set up this incident group, and that recall process. So as soon as we identified that it was clinical harm, we recalled those children.
A comment that I'm very disappointed, to be honest with you. I had no idea that this had gone on at all. I did have a responsibility for children's services for 10 years. I wasn't even aware of it. This was.
I think if I may just make one final response that our monitoring, our oversight of that service, there were no previous cases of harm identified. So we, in the years that children have been coming back to services for review and follow up, and with other agencies involved, we haven't identified any other harm. This is very much we want to make sure that we understand whether harm has been caused. So we're doing these case reviews. And we have identified some instances where that has been the case. The full learning from those cases and all of the contributory factors, of which we believe staffing will feature strongly, would welcome the opportunity to come back and talk to members about that.
Okay, thank you. I've just got a couple of questions to follow up on what my colleagues have been saying. I think they've asked all the pertinent questions. Just want to follow up on the workforce pressure issue. I mean, you were saying that at the moment you're still waiting for the results of your investigations into why things went wrong. But in your report, you say that testing and hearing aid management that did not fully meet national best practice standards. This was due to significant pressures on services linked to complexity and demand, which you've spoken about, but most significantly, workforce pressures. I mean, so is that you're saying that the most important factor in this was pressure of shortages and workforce pressures, recruitment, and staff shortages?
I think when we apologies, Chair, I'm struggling to hear slightly, but when we present the review, there are two slightly different categories of children within the cohort. The first are those that have been fitted with hearing aids, but that hearing aid has been set or adjusted suboptimally according to the results of subsequent hearing tests, and we need to understand how that has arisen and where. That's a relatively small group of children within the cohort. And the second, where the volume of the cohort is coming from, is that children have been reviewed by the service later than would have been clinically optimal. So perhaps if a review was scheduled for 6 months, it hasn't taken place for 9 months or 12 months. And that is because of workforce pressures. So there have been pressures on individuals running the service, and also then the workforce pressures around the capacity for the service. Again, we need to go through all of the root cause analysis, the chronologies of those patients, and make sure that we can present that fully to you to be able to provide the assurance that we understand fully what's happened.
Okay, thank you. Just to follow up on that, we're talking about the schedule of assessments and children missing assessments. Presumably it's known that if a child misses an assessment, then that is a suboptimal treatment. So does that not raise a red flag? Should that not have been picked up for each of these individuals that it's happened to? Should that not have been picked up at the time?
I think that these are issues that we will explore through our sort of wider incident investigation as to overall what went wrong. Did we have inadequate follow-up process in place? Was it just workforce? What was the relationship with primary care? What was the relationship with sort of, National Deaf Children's Society? So there's a whole number of factors that we do need to look at. But the most important thing we think at the moment is to get those harm reviews done and to make sure those children are treated. And then obviously, as we articulate later on, we will get that wide report and see exactly what went wrong and what would prevent this happening again.
Okay, thank you. To follow up on Councillor Ahmed's point about giving reassurance about future practice, and I think this is obviously, I think this is the most important point, isn't it? That we have some kind of reassurance that obviously, I guess there's still a risk that still a risk that this sort of thing might happen to individuals, but that I think we need reassurance that the system and the processes are in place to prevent this happening again. So I think it would be good. It'd be good for you to give us that reassurance now.
So I think we've taken some immediate steps which have been quite important. So the first is making sure we've introduced that clinical triage and re-triage. And when parents or carers of children under the service contact us with concerns, we reevaluate urgency and make sure that we bring children in as required. We've moved the waiting list and appointments information into an electronic system. Audiology is a specialist service and hasn't been on the main trust's appointment system. That's not uncommon, but unfortunately in this instance it wasn't computerised. We've now done that, so we are able to interrogate and understand immediately whether patients are overdue for an appointment or a follow-up. And then we've been working with colleagues in local authority services, but also in children's services for the NHS to raise awareness of this incident. And by sort of professional alertness to the risk, we hope that that is also mitigating the chances of any other child coming to harm.
Okay, thank you very much. If there's no further questions, just like to thank you for coming tonight and presenting this update. We're asked to note the update and also the continued commitment of the Trust to further develop and strengthen its paediatric audiology services, which you've obviously given us that tonight. So I think we can note those recommendations. Oh, Councillor Hussain.
I would like to see a report back in 6 months' time.
Yeah, indeed. If that's or if when would be an appropriate time to, presumably when you've got to the next stage of your investigation?
My expectation would be that within 6 months, we would like to come sooner if we can, if we finish the review. So, but 6 months should be sufficient time for us to do that.
Okay, thank you. Yeah, 6 months it is then. Thank you. Okay, thanks very much. Okay, if we go on to the next item, improving resident experience of access to primary care in Luton. And I believe this is Amanda on Teams.
Hi, good evening. Okay, if I just take a moment to introduce myself and my colleagues who are joining the meeting this evening, and then I will give headlines from the report, but in line with the previous discussion, we've got the benefit of Dr. Manjur Ahmed with us today, who is a GP in Luton, and also Phoebe Logan, who is Head of Community Pharmacy Improvement and who is a pharmacist. I think at the previous meeting where we discussed primary care access, we all noted it would be helpful to have those clinicians present to enable a full discussion about the changes in general practice and particularly the triage model that has been implemented. So I'm Amanda Flower, Deputy Director of Neighbourhood Health, Place and Partnerships, Primary Care in BLMK, and I'm joined by Maria Wogan, who is Director of Neighbourhood Health, Places and Partnerships, again for BLMK. And as I've already explained, we're joined tonight and we have the benefit of Dr. Monjour Ahmed and Fumi Balogun. So I'll give some headlines from the paper that we presented to the committee, which follows a consistent form to previous papers presented to this committee. As we've described in the paper, all of our practice in Luton have transitioned and in line with the national contract have implemented a modern practice access model, which relies on a triage approach. This is intended to remove the first come, first served approach and ensure that appointments are allocated based on presenting needs. Regardless of how patients contact their practice, whether that's by telephone or attending or completing the online consultation form, the practice will seek a consistent set of information from each of the residents. This will allow the practice team to take a view on the best service to support that patient, which may or may not be an appointment with that practice. It may be signposting to other services, such as the community Pharmacy First scheme. Consistent with previous papers, what we've highlighted is that we continue to see high demand for appointments in general practice. And alongside that, we see a rise in the activity that our teams are providing. We've seen for the period reporting in the paper, a 10% increase in activity delivered by practice teams in terms of appointments. We've given some early data in the paper this evening regarding the online consultation system, where we're seeing a 16% increase in the utilisation of that system between September 25 and January 26. And you'll see that those numbers of requests daily are quite significant. The telephone data held by practices has some anomalies and some difficulties, but what we can extract again shows a high call volume to each practice each day, and that continues to rise. The data does demonstrate that there are some calls that are missed, and this is an area that we are continuing to support and work with on our practices, because we recognise this can continue to be a frustration for our residents. I've touched on the triage systems that practice uses, but I will now turn to Dr. Monjour Ahmed, who is a GP in Luton, as I've explained, who will be able to explain for the committee in more detail how clinical triage works, how total triage works, and the safety measures to ensure clinical safety for residents that is followed in general practice. Monjour, over to you, if I may.
Thanks, Amanda. Can you hear me all okay? Hi everyone, my name's Dr. Monjour, as Amanda said, and actually before I carry on, a few weeks ago I was also the access lead, the strategic lead for BLMK ICB before it merged with Central East, and I think that's relevant because for the last 3 years or so we were really honing in on that data around access and how we improve access for patients, particularly focusing on reducing inequalities. Now, just going back to the triage was something that was essentially imposed upon general practice through the national contract in order to improve access to general practice. And as you all know, being residents of Luton, and anyway, actually nationally, access has always been a hot topic around general practice, and we always hear the age-old complaint that I can't get a GP appointment. I was born and raised in Luton, and I'm a partner in Luton, so access is a big thing for me as well, not just because I'm a GP, but also I'm from Luton and I want our residents to get the best deal possible for them. The way it works essentially is patients will fill in an online form, which we've tried to keep as simple as possible, but there are different software providers that offer different solutions to this. And then on the other side, a clinician or a trained person will then review that request to decide the priority of that patient and whether they need a face-to-face appointment, telephone appointment, advice, prescription, etc. Alongside this, we've been mandated to ensure that our phone lines remain open, so you can also access the practice through the phone lines, and our front doors must remain open so you can also access appointments and support through the front door going to reception. And I guess the reason for this was to ensure that those that are struggling with digital literacy do not become isolated. We're thinking about elderly people, people who maybe aren't IT literate or don't have English as a first language, and we know that a lot of practices in Luton have a demographic that fits that quite closely. So the phone line should still remain open and the front door should still remain open. And we've seen in my practice, I think we went live in August 2024, something like that, that the uptake of the triage service has been phenomenal. In fact, it's probably been too successful in the sense that we've seen demand go through the roof in terms of the online. The phone lines have quietened down slightly, but as the data you could see in Amanda's report, there's still a lot of phone traffic coming through, as well as people coming to the front door. And the reality is something like a triage-based system, it's a real culture change, and implementing behavioral change amongst an entire patient demographic, it takes time. And I think we've tried to navigate through those difficulties as best as we can. And it's important also to remember that GP practices are independent providers, essentially. So not everybody does the same thing. Everybody takes a different approach. And again, in my previous role as the access lead, our plan and what we tried to do was really ensure people were being consistent, allowing people freedom to kind of address their patient demographic the best they can because they know them the best, but also have some consistency. So we were analyzing data month on month, quarter on quarter, and highlighting those practices that are falling outside of those kind of ranges that we felt were appropriate, and going out, meeting them across the patch, speaking to them, offering an olive branch, seeing how we can support them better to try and improve the uptake and deal with some of the issues. And alongside that work, we were going to regular health watch meetings and meeting with patient groups just to kind of hear the other side of the story, because it's all well and good sitting in our silo thinking we're doing a very good job, but the reality is this is all about the patients, and for me it's always been about the patients. So we've always tried to make sure that the whole point was to improve access for patients. So if we're not checking in with the patients and seeing how they're doing, it kind of doesn't make sense. So that's how triage works in a nutshell, and the kind of safety and governance we have around it to ensure that patients aren't missed. I'll stop there.
Thanks, Monjour. And I suppose just to add to that, Monjour's described the practice visit programme and the support that we put around practices to identify and address variation to ensure that we have some consistency. That wasn't just a retrospective offer. We continue to work in that way to support the practices in Luton and indeed across BLMK. So that continues as a practice visit programme to ensure that we are delivering the requirements of the contract, but we support practice development. Happy to take any questions now, Chair. Thank you.
Thank you. Okay, does anyone have any questions? Councillor Hussain, then Councillor Moore.
Can I ask you, I mean, in terms of the telephone call, that was one of the biggest, the appointments were gone and all that before 8 o'clock. That, from what I get from the number of calls that I've got from it, is that when they're asked to get a phone call back, they don't get that call for hours on end, even though they made it, they have been assessed, the GP phone call will be made.
I think in order to answer that question, I need to outline the way it works, Councillor. So, for example, on a Monday morning, at between 8 and 8:30 or so, we'll probably get in my practice, we get about 250 requests for an appointment. And then a GP has to go through each request and decide, okay, that needs an appointment, that needs an appointment, that needs an appointment. I then, through the system, send a message to reception to book that phone call or to book that face-to-face. And that takes a period of time. So, for example, of the 200 appointment requests, probably I would deem 100 or so, it's usually about 50%, I think, need an appointment. The ones that I can deal with as the triaging clinician. I will deal with send a prescription, send a text message. The ones that need a proper phone call appointment, I will then ask reception to book with another GP that's in the practice on the day. Now, those GPs have rotas that are on throughout the day. So, for example, it may be that I've asked reception to book an appointment and the first available appointment with that GP on that day is at 3 o'clock in the afternoon. This is why they wouldn't get a phone call straight away. They will get an appointment. Now, we had a lot of feedback from patients saying, okay, I put in a triage, but I didn't hear anything. And through my access role, we were asking practices to try at least give the patients an idea of when to get a call. Because if I've put in a triage, I'm just sitting by the phone all day. I don't have a clue what's going on. And so I agree with you in a sense. Practices need to be proactive in informing the patients that they have an appointment. So in my surgery, they will get a phone call from the reception team saying, we've seen your triage, doctor will call you around this time. And we kind of keep it AM on PM because we can't get much more close than that because you just never know what happens on any given day. So at least my patients know that, okay, I'll get a call between 1 and 4, or I'll get a call between 10 AM and 1 PM. That's how we do it. And again, the difficulty here, Councillor, is some of your constituents may be referring to their specific practice, and it's very difficult for me to answer a question about a specific practice. But in general, I agree with the sense that patients should get an idea at least when the call is coming or when the appointment will be booked. It's much easier with face-to-faces because they'll get a text message saying, please come in at 10:40 AM. With the phone calls, it's much more difficult to be prescriptive around times, but we still need to give patients an idea of when they'll get a call. Otherwise, it's very frustrating for patients. And I understand that wholeheartedly.
But what I'm talking about is the example I'm giving you, where a person has taken the call, then referred it to physician. Physician said, no, you will get a call from the GP. This was a call probably 10 in the morning, and they hadn't even got a call back from the GP till about 5 or 6 in the evening, or not at all. That's what I'm talking about. This is the one or two incident, and even at a personal experience, I can tell you that call I made today, as an example, GP was to ring me back, and I still haven't got it.
So again, we have to differentiate between specific isolated examples and generally what we do. So as I said, generally, if my surgery has said to you that you will get a phone call from the GP this afternoon, you should get a phone call. Now, if you haven't got a phone call, I can't answer that question because that shouldn't have happened. Okay. Even now you said, Councillor, you're waiting for a call and you still haven't got it. I can't answer that specific question, but if you've put in a triage, they should have told you you'll get a call this morning or this afternoon. If they haven't called you, then that doesn't make sense to me. And that's probably a specific individual issue that they have to take up with the practice themselves, because that shouldn't be happening.
A couple of elderly people who had made a call first thing in the morning, talked to the physicians, and still didn't get a call till 6 in the evening. They have been sitting by that farm just in case the call comes from the GP. And I'm talking about those vulnerable people, which is what I gave an example last time. There are vulnerable people who really and truly not able to do it online, who have to do it on the landline telephone. Yeah, not very familiar sometimes with even with the mobile phone. That's the one I'm talking about. And they're pretty isolated, elderly people living in the world that I do.
Yeah, and again, Councillor, I'll reiterate that shouldn't be happening, especially for the vulnerable patients. They should be given an idea. My view is every practice should be giving their patients an idea of when the call will come. So if there's an elderly vulnerable patient who's put in the triage, waited on the phone, being told, okay, you'll get a phone call, and the phone call never comes, that's a specific individual isolated case. And it's almost impossible for me to answer that question. If that was to happen in my surgery, I'd be investigating why that's happened internally with review with the patient. I can't answer that question on this forum because it's a very specific, isolated case. I'm sorry that doesn't answer your question really, Councillor, but it is a very specific example you've given, and my view, and I think the view of the ICB would be that that shouldn't be happening at all, and that patient needs to speak to that practice or have a representative of themselves speaking to the practice, asking why that's happened, because it shouldn't be happening. And you're right, it puts vulnerable patients at risk. And the whole idea of the triage system is to reduce that and reduce health inequalities. So if it's happening, it needs to be looked into on a case-by-case basis. And the ICB is happy to look at this. If you contact the ICB about these specific examples, we can take them back and look at them specifically and find out what happened. Because the only way to stop it happening is to look into why it's happening and then try and address it.
Yeah, so I've got a couple of questions. I'll start with the one that kind of semi-relates to that. Is in bullet point 15 on the report, you talk about obviously how the menu directs people as an option to complete an online consultation with a significant amount of people ringing off during that menu. What care is taken with the wording of that menu to ensure that it doesn't feel like people are forced to use online if they are not comfortable to do so? Because I don't know about my colleagues, but I've obviously heard people from my constituency mention to me that, oh, you can't get an appointment without going to online, when we know from this meeting that that isn't the case. So what care is taken with those comments in those menus to ensure that the patient is aware of all the options?
So the response to that is actually quite simple. As per the national contract, there should be no practices saying to patients that the only way to get an appointment is through online. That is an absolute breach of the contract that we're working to. So if there is a practice that says to the patient, either on their online menu or over the phone or whatever, that the only way to get an appointment is through the online system, then that is wrong and that is a breach of contract, and those patients need to raise that with their practice or raise it with their counsellor or ICB, and we can look into it, because that should not be happening. Is that correct, Amanda? Did you want to jump in?
Yeah, no, absolutely. I was just going to support that, Monjur. Thank you. And I think that's consistent to what we've discussed in this meeting previously, for specific examples where they shouldn't be happening, people being waiting a long time for a callback as described earlier, or people being forced to use online consultation systems. As an ICB, we would ask residents to raise that with the practice manager, but my email address is in the paper that I've provided tonight. I'm very happy to be contacted about those, and I will take it through our contact us and our complaints response approach, because it's really important that we investigate those individual items and respond appropriately. So absolutely support what Monjur has said.
And also some of the work we did, Amanda, you'll recall, we looked at some of those practices where we were getting such complaints as individual practices and approached them and tried to find out what was going on, because as I said, it should not be happening. That's not to say that it doesn't happen, but the point is it should not be happening.
Yeah, I mean, maybe I'm too trusty. I don't believe that is a situation in the situation I'm suggesting that it is happening. I'm just aware that sometimes people can take from a wording of something that isn't the case. I.e., you can say, oh, you can't, someone goes on a menu, oh, you can do this, you can do that. What I'm saying is what care is taken on those phone menus to give all the options so people aren't misunderstanding the situation.
Well, interestingly, all the software providers that you can use for triage, so I'll give some examples, although they may mean very little to you guys, is System Connect, AccuRx, Clinique. These are all software providers, and they all work and they're all able to provide this service because they are approved by the NHS England. So they would not be able to be approved if they were presenting wording that was not appropriate. They're not really allowed to do that. So practices may tell you that, okay, online is the only way, but the software doesn't really allow you to do that because it has to be clear in order to be an approved supplier. Now, if practices have gone on and changed the wording and they are limited, by the way. I've tried to change some wording to save my soul at times from triage because it's so never ending. There's very limited changes I can make to the wording because it just won't allow me to do it. And so again, if patients are misinterpreting the wording, again, that's something that needs to be taken up between the patient and the practice, because actually if the practice is wording it in such a way that it seems like an obstruction to the patients can take that through their practice, through their PPG, and ensure that wording is more appropriate. Now, obviously, it's difficult when it comes to a limited set of words to make it accessible to everyone. There will always be different interpretations made of a small paragraph, but if it's a common issue within a specific practice, that needs to be raised directly with the practice. I feel as though I'm not really answering the questions, but I'm trying my best to do so, only because we have, 25 practices in Luton, there and thereabouts. So sort of, and this is the wrong word, policing every single practice is very difficult. We rely on feedback from patients, patients feeding back to their practices and patients feeding back to the ICB is the way that we can make those changes happen and ensure that there is as much as possible consistency throughout the patch.
No worries, that was much more. Well, that was much more. That was kind of the point I was getting at. So you answered that very well. The other couple, I'm sure you probably won't be able to answer it. Is just on bullet point 10. It's mentioned that there's practices have offered. Well, it's 137,500 basically appointments, and then it's a 10% increase. There's a couple of bullet points there. 47% of appointments are offered same day. 57% of those appointments are face to face. I'd like to have seen in the report, just like the main heading, where that compares with the year before, and the same would be true of the points made in bullet point 15. I'd like to see the comparison with like 12 months previously.
I respond to that. That's a fair point, and we can provide those comparable data sets. I can tell you that the previous period, I think we've seen a fairly consistent level of face-to-face appointments and appointments with a professional other than a GP. That stayed fairly consistent throughout the reporting period. But in future reports, we'll provide more comparable data across the periods consistently throughout the paper.
I was just going to add as well, sorry to interrupt, that there was a period after COVID where there was a misconception, I would say, that there was no face-to-face appointments available. So there was a big drive towards recording face-to-face appointments within practice. And actually, what we've found since we've gone live with triage is a lot of patients prefer telephone. There's been cases where I've had to speak to patients and say, look, you need to come in because I need to see this thing that is growing on your back. And I can't do that over a face-to-face or a video, but patients prefer to do things over telephone. So what we found more recently is actually recording the amount of face-to-face is not as valuable as it used to be. Because as you offer patients choice, many of them are opting for telephone, even when the triaging clinician, myself, feels a face-to-face is more appropriate. You know, just before I went on leave recently, I had a pair of 3 children, all below 4, uncontrollable high fevers, and they wanted a telephone call. And I said, I need to see your baby. But they wouldn't come in. So this is the other end of the spectrum that we're trying to deal with, where patients now, given the choice, they prefer telephone because it's more convenient. I understand that, but there are certain things we have to see face to face. So coming back to the point, Amanda did include face-to-face appointments in her report, but I don't feel as though that is as valuable as a number as it used to be, because the way people access practice has changed completely over the last few years.
It kind of comes back to my point about comparative data, because if we see a 30% jump or drop in that kind of thing, we'd like to, that obviously something we'd like to know, and then want to know a reason for it, and a reason like the one you just mentioned exactly. But it's those comparable figures that give us a lot more leeway to understand the report better, because Otherwise, without particularly, say, in a year's time when we might have a different cohort on this committee who might not have a history of the last 7 years' reports. That's why getting comparable numbers is more important than just having numbers on their own.
I agree with that, Councillor, and actually I'm sure we have that data because we've been looking at the data for many, many years now. And interestingly, once we were mandated to go live with total triage, which I think was around 2024, you will see there was a huge jump in total consultations. And actually, if we were to provide the further report, which I'm sure we can for the next meeting or whenever it's requested, it'd be useful to come with a bit of context as well, Amanda, because there has been lots of changes that maybe patients may not be aware of around the GP contract and what we offer and what we don't offer and how the data is extracted through a system called GPAD. That data is available, and I'm sure whatever we can share, we will share. But adding a few years worth of data will show the significant increase in general practice capacity that's been offered, as well as adding some nuance to the data around video consultations, face-to-face consultations, telephone consultations, because I think historically, and this is me just kind of flying the flag for general practice, I think a lot of things that GPs have done over the many, many years has gone unnoticed because we're very bad at recording the data. And what the government is doing now, which I think is a good thing, is ensuring that everything we do is recorded. And so you'll see significant spikes in the number of consultations because actually we're finally starting to record everything we do. And that's a good thing for us, but it's also a good thing for panels like this panel because you actually get to see raw data and you see the numbers increasing exponentially, I would say, considering the capacity hasn't increased. We don't have more GPs. If anything, we have less. So something's going on here. And I'd like to think it's because we're working much harder and much more efficiently. Although many may not agree with that if they can't get an appointment.
Thank you. Pat.
It'd be interesting to have data on face-to-face and telephones between different practices. You know, whether some practices do lots of telephones and some do lots. And I do get, because I would prefer a telephone call myself, but we do get feedback from patients that say we're only offered telephone consultation, we're not offered face-to-face.
If I could come back to that, I think in relation, in response to that point, Pat, and to the other point, we can definitely, perhaps for the next time we schedule a primary care access report, take a broader view at the data changes over a wider period of time, and we can give the range of the percentages in the data. So for a percentage, like the number of percentage of appointments face-to-face, we can show the range between the 23 practices in Luton, so you would get a sense of the high and the low volumes of that. So we could definitely give a more data-orientated report to a future committee.
And I would also add any practice that is only offering telephone consultations and not face-to-face is absolutely not doing the right thing. And so we would want to know about that because that is not appropriate at all. I don't think that's the case. Often, you know, what a patient tells you may not be the reality. But if there is a consistent theme around a specific practice saying they only offer telephone calls, that does not add up to me at all.
Councillor Bacon.
Thank you. I think in November, I did ask Amanda, I don't know if you remember, that we wanted to see the difference between the data and patient's experience. I think that was the question I asked to see in the report, that maybe it would be good to have. I know the report is saying this has happened, we've done this has been better, and so on. But my colleagues here will have caseworks, and I think my colleague just also mentioned there will be residents that we have seen, we have spoken to, we have supported, who will say, well, I can't get an appointment, can you help come to our surgery? So we do want to see patients' experience. What are they saying, not what we are seeing on report, please. Thank you.
Yes, we can try to do that through, I suppose, using individual practice feedback and data through their patient participation groups and the work that individual practices do. There is also the annual GP patient survey, which is published every July. So when I came in November, the report was a few months old. So we're heading into that period now where we'll have that new annual patient survey data, which is still it has constraints, it comes with caveats, but it is still the source of patient feedback that we use in relation to primary care services. So again, we can bring that into a future report after July when that updated information is available to us.
Okay, thank you.
Amanda, I was just going to add, with Pat's in the meeting room, isn't she? And at the Health and Wellbeing Board meeting last week, Healthwatch presented their annual report, which also gave some patient experience information around primary care and around access and the changes that have been made to triage. So we may can do something with that with Pat as well on that.
Pat, did you want to respond to that?
Well, I will say that patients' experience, as in their experience with the doctor, was positive. You know, like that after their consultation, it was positive. What we found was that people that found it difficult to get an appointment were offered a telephone appointment. And it was only a quick survey, it was not an in-depth survey. And people that found it easy to get an appointment actually got face-to-face appointment, whether that was because of their needs. You know, it was just a quick survey we did last summer, 4 questions on a postcard in community events last year. But everybody said their consultation with their GP was a good experience. Yeah.
Chair, can I just clarify? I think I was saying access to getting appointment. That's the report that I was asking for. So you know the online module, I can access it, go on at 6 o'clock or 8 o'clock and do the form, and I'll get an appointment, phone or face to face. But like Councillor Mahmood said, if someone can't get it, and those who, as Pat said, those who can't get an appointment, what are their experience? That's what I'm saying, not the experience with the GP or the surgery itself, is them getting an appointment, the access, because of this new system.
Our report was on access too. It was asking people, did they find it easy to access the service? Could they access the triage service? I can't remember the questions, but the report is on our website. Yeah.
I just wanted to add actually that I'm working with the University of Bedfordshire with a PhD student who's been funded to do some research around experience of access in Luton practices. Her name's Karen, and she's just due to start the work this week. And I think it will be a really interesting piece because it will be looking at speaking to GPs, but also speaking to a significant cohort of patients. And the patients we've identified are those marginalized groups. So elderly people, asylum seekers, specific ethnic minorities, English as a second language. And she'll be looking at the experience of access of the new kind of models of working from those specific cohorts. So I think actually, and the reason I'm supporting that piece of work is I think it's really important, and it ties in, Councillor, with what you were saying. How do those marginalized groups experience getting an appointment and getting access? Because actually, if we don't address those needs, we're kind of falling flat. As you said, you can get an appointment, but we need to try and find a system where everybody has equality when it comes to getting access to their GP service. So there is some research going on, significant piece of work, and once that comes out, hopefully that will be shared widely and will inform, hopefully, national work around access to general practice.
We did do a piece of work with the Gypsy and Traveller community up Stopsley after they had trouble accessing services. And earlier in the year, we went and did secret shoppers. We went up to the Travellers site at 8 o'clock in the morning and got them to phone the GP practices up Stopsley. And I can tell you that they all got through on the telephone, no problem whatsoever, which was a problem they'd had previously, a couple of years ago. But yeah, they all got through. They all because they're not digitally accessible, and they all got through on the telephone through the triage system.
What's interesting is the whole idea of triage was the people who can use the online system, they should, and that should free up the phone lines for the vulnerable patients and the marginalized communities, and also free up the front door. In reality, it hasn't happened fully because people still think that I'm just going to phone at 8 o'clock. And as I said right at the beginning of this presentation, changing culture and changing behavior of an entire demographic, it takes time, and we have to support patients through that time, and it won't happen straight away. Bear in mind, triage has only been going for about 2 years now. You're not going to change the behavior of an entire nation in 2 years. But I think what we have done so far is show that it is a better system in terms of capacity. Now we need to work on refining the little specific details to ensure we don't miss anybody out. As I said, with the triage, you have models which are very complicated, fantastic. They kind of sift out all of the stuff that isn't needed, but it takes a long time. And so a lot of people give up. And I've had experience of people saying, I'll give up. The software my surgery uses is very easy, really simple. The problem with that is at least 10%, 15% of the triages we get every day is just someone who writes, I am sick. I can't do much with that. It just says, I am sick. No other details given. So the time taken to then go back to the patient, what do you mean you're sick? Back and forth, and all the while more triages are coming in. So finding that happy medium of getting the right information, but also not making it too onerous to sort of put people off, and therefore creating digital exclusion and inequality, that balance is difficult. And I think every practice is on their own journey to find that.
Okay, thank you. If there's nothing else, I'll. Sorry, yeah, Councillor Sturt.
Yeah, just very quickly. Thank you very much for coming on. It's all been really interesting. Does the software itself triage, or does it? You're laughing, or is it always a person who's looking at it?
Right, I'm going to go off piste a little bit here. So there are software providers coming out that will autonomously triage based on patient responses. My big issue with those software providers is they are really complicated. I've tried using them myself, and I'm a GP, and it takes a while to go through them. When I was deciding what to use for my surgery, I decided against them because I thought this will really exclude a lot of people because they'll just give up at the third question because they're quite specific. In order to safely triage people through a software, which is validated, by the way, so they are safe, you have to go through these specific questions. And now some surgeries have decided, you know what, we don't want to use those because it's just going to be too difficult for patients. Other surgeries have decided we will use those. I'm not here to say that they're good or they're bad. My own experience is that some of them are very complicated because they need to ask complicated questions in order to sift out the serious cases and the non-serious cases. So in answer to your question, yes, some of them do that. Some of them don't do that. And each surgery, it's up to them which one they want to use. I can't really tell surgeries what to do. I can just do what my surgery does. But the difficulty is with the demand, and again, this is me being honest, with the demand going up and up and up and the changes to the GP contract, I suspect many more practices will move towards complex triage software in order to just be able to manage their demand and survive, which I don't think is a good thing because we'll start creating digital exclusion. And this is the difficulty. And even if you phone the surgery, the receptionist will still go through that software. So they'll still have to ask all those complicated questions, which ends up being a 15-minute phone call with the receptionist, only to then go to the GP and get another phone call. I don't think it's an efficient use of time, but that's my own personal view.
Thank you. Gosh, sounds like you're quite good advert for your own practice, which sounds good. And they're all NHS approved software. So what you're saying is there's a big range of software available to GP practices. And do we know what sort of range we have across the borough or the?
I mean, there's a couple of big ones, and Councillor, you'll appreciate from the ICB perspective, collating data is difficult and often not very consistent, although the NHS England is trying to change that because software providers all pull the data in their own separate ways. And so for an ICB to monitor what's going on, it has proven to be difficult, Amanda. And we have developed quite sophisticated quarterly and monthly reports to try and extract it as much as possible. And something NHS England and the government has been really keen on is how do we bring that data collection into a more consistent model? Because if you don't have a consistent model, it's difficult to compare. Going back to Councillor Begum, I think Begum's question around the data and comparing practices, if different practices are using different systems, it's really hard to then compare them because the data extraction isn't consistent. But that hopefully is changing, and I know the Secretary of State at the moment is pushing towards bringing things in line so patients have the ability to make a more informed choice around their healthcare, around which practice they join, because they should be able to see that data. And that should be coming, but it hasn't come just yet.
Thank you for your answers and your help.
Okay, thank you. Yeah, just to reiterate that, thanks for coming along tonight, Dr. Ahmed, and thanks to Amanda as well. Just one point. You've given a very eloquent and very thorough accounts of triage and access at your practice, but I get the impression that if another GP from another practice came along, they might give a different picture. Is that a fair comment?
I don't think so. I mean, I think all GPs have this ego about us, which makes us think that we're really good at everything that we do. The reality is, my experience across the patch is lots of GPs are working in different ways, but all I do know is they're all trying their absolute best. And now that may sound very fluffy to a committee. There will be practices that are operating differently. I agree that probably different GPs will say different things to you, but luckily we are all working towards the same blueprint. We have a GP contract that we are working towards. That's what we need to work towards. And if we are all working towards that, then technically we should all be doing roughly the same thing. If you really want the experience of the patients, you need to look at the general practice survey, and you need to speak to HealthWatch, and you need to speak to PPGs, because that's where you'll get the real experience. Asking the GP how they're going, it's potluck, isn't it? Everybody will say they're doing a good job. And sometimes, and I always say this to my colleagues, sometimes the hardest thing is to put your hands up and saying, actually, we're a bit crap. But that's okay, because identifying your weaknesses is the first step towards getting better. So I always welcome patient feedback, and we always have done. And we always turn up to HealthWatch in my access role. And the first half an hour is always patients having a go at me. Because unless you really engage with patients, you're never really going to know. So what I always say to my patients, and coming back to your initial question, is if you really want to know what's happening, you need to speak to the patients, not necessarily the GPs. And that's me as a GP saying that.
Okay, thank you very much. Thank you again for coming along tonight and presenting. I think we obviously need to have some more discussions about how we present this report at future meetings. Okay, thank you very much. We go on to the next item. That's item number 9, the ELF Social Work Improvement Plan. Jill?
Good evening, Chair. This is a report that was put forward by myself, but I've got my colleague here from ELF, Michelle, the Director of Operations, so we can answer any questions jointly. It's a brief report, just really reflecting that we had a peer review by the Local Government Association, which we requested. Because we wanted to understand the situation. We knew there were some challenges. That was something that we actively did in order to get an objective view and to take forward an improvement plan on the back of that. So the improvement plan I think it's fair to say it took a little while to be really be getting any grip and get established, but I think we're over that now and are leading those improvements, and we are monitoring that through a joint social work improvement board, which the Michelle's colleague Mary Brazier, who's the director of social work for Elft across the whole wide of the trust, as the specialist input, chairs that meeting, and Michelle and I and other DASs from the Bedfordshire region also attend. So over to questions.
Okay, Councillor Ahmed.
Thank you, Chair. What measurable improvements in frontline social work practice or outcome for service users have been achieved so far as a result of the improvement plan rather than just governance or process changes?
To answer, because essentially this is meant to be about governance and ensuring that things are done well, not just done. So I don't think that that's necessarily an easy question to answer, because what we're trying to do is be able to, particularly for myself as the statutory responsibility holder, to be able to have the evidence to demonstrate that everything is done safely and on time and to a measurable effect. And that wasn't as tight as it needed to be. So it's about getting that monitoring and that governance right. That is really important. Then we will be able to understand in more detail where there may be gaps in provision or things that we needed to improve. So it's a little bit difficult to answer that, because that's essentially why we've set up the board. However, what I would say is that there has also been some clear development of training with some of the social work staff that has been related particularly to mental capacity training and other areas that were identified both through the LGA review to an extent, but also through our closer working now with the principal social worker from the council, now working much more closely in that practice governance meeting and with the staff and in joint kind of practice development areas. So I think there's been improved practice as well. But we're not really aware of kind of anybody not accessing services. So those kind of things we wouldn't be expecting an improvement in that as such.
Responsibility shared between ELFT, the council, and the ICB. Who is ultimately accountable when social work performance or safeguarding practice falls below expected standards? And how is that accountability enforced in practice?
So that's a really good question, and kind of one that we've tried to outline a little bit in the paper. I guess it's a kind of a mixed responsibility ultimately. So Michelle and Elft would hold the operational responsibility for that, and they can be held account to that via the contract which the ICB holds. So contract management processes can be put in place if there were any significant failings, etc. And Elft need to report to the ICB and to us. They do it to us at the same time. We don't mess around with that about their performance measures. And so then the ICB has a responsibility to make sure the contract is working appropriately. But I also still hold that statutory responsibility. And so ultimately, that's why I need to work with the ICB colleagues and with Michelle and colleagues to make sure that everything is all happening as it should. So it's a bit of a shared thing, really.
If I just come in, Jill, thank you. I just want to say that actually when the peer review was undertaken, one of the strengths that they identified was the safeguarding arrangements and the oversight from the local authority in terms of there. So we can assure you that actually those processes are assessed as being robust in terms of the peer review.
Thank you.
Anyone else? Don't think I've Oh, just the one question. There is, so talking about the peer review, and you're talking about the Social Work Improvement Board and the Practice Government Board, and there's it would be, I think it'd be helpful if we could have links or how we can access all of these this documentation and these various bodies. Is that something that could be, because I'm tried to have a look on both websites, council and Elft websites, and I was having a bit of difficulty trying to find any of the information that was in the report.
Yes, so they're not documents that are automatically published. They're not necessarily in the public domain. We don't need to publish or peer review or anything, but I would be happy to share that with members. But certainly the Social Work Improvement Board, that's not a public document, that's an internal process. It's not a formal, public space, but I'm happy to share the LGA review with you. In fact, it should have been attached as a supported paper.
Okay, thank you. I mean, yes. I mean, I guess we only want to see anything that would be useful to the work of this group, rather than, yes. Okay, yeah. Thank you. If there's nothing else, we're asked to note the report, which I think we can do. Yeah. Thank you very much. Thank you. Okay, if we move on to item number 10, the Luton Carer Strategy Year 2 updates.
Thank you, Chair. This report provides a short update on progress delivering the Luton Carer Strategy 2023 to 2028 and says out how the Council is continuing to strengthen support for unpaid carers as we move forward into Year 3. So unpaid carers play a critical role in supporting some of Luton's most vulnerable residents. The 2021 census identified around 16,000 carers living in the borough. However, the number of carers currently accessing support is significantly lower, which highlights an ongoing challenge around identification and the number of carers who remain hidden. Supporting carers effectively is therefore not only a statutory duty under the Care Act, but also central to delivering the Luton 2040 ambition, particularly around improving health and wellbeing, reducing inequalities, and helping residents to remain independent for longer. This report highlights 3 main areas of progress during Year 2. First, strengthening and reshaping the carers offer, the support offer. Over the past year, we've worked closely with carers, partners, and voluntary sector organisations to review and redesign the community-based support service. Through co-production, carers were clear that they want simpler access to support, clearer information, opportunities to connect with others, and practical help at key points such as crisis, hospital discharge, and transitions in their caring role. In response, the Council has commissioned a new community carer support service, which was launched on April the 1st. This brings together information and advice, peer support, targeted one-to-one support, and stronger links with community and health services. The aim is for a more visible, consistent, and joined-up carers offer for carers across the borough. Second, expanding reach, particularly through digital support. In October 2025, the Council introduced a digital 24/7 carer support offer through Mobilise. This has helped us engage with a much wider group of carers, particularly those who had not previously come into contact with services and working carers. Since launch, over 3,400 carers have accessed the platform, with more than 700 engaging in more personalised support. Around 3/4 of these carers were not previously known to services, which reinforces the scale of the hidden need and the importance of offering different routes into support. Digital support sits alongside rather than replacing face-to-face provision, and the new service model has been designed to ensure that carers can access support in ways that work best for them. Third, improving awareness and identification. Many carers do not recognise themselves as carers until they reach a crisis point. To address this, the Council launched the I Care awareness campaign, co-produced with 6 local carers whose lived experience shaped the messaging materials, including posters and videos, to increase visibility of caring roles and to encourage earlier engagement. The campaign has achieved strong initial reach across social media, community settings, and health partners, and will continue to support the wider system in identifying carers earlier and linking them into support. We know that some carers are underrepresented, particularly in diverse communities and among those who don't identify as carers. We're addressing this through targeted outreach, including equality, diversity, and inclusion roadshows, and the new community carer support service, alongside strong VCSE partnerships. The digital offer with translatable information is helping us reach carers we weren't previously seeing, and co-production is making carers more accessible. So looking ahead to year 3, the focus shifts from redesign to embedding and strengthening delivery. This includes ensuring consistent implementation of the new service model, improving insight through the carers dashboard, strengthening partnership working, and continuing the close gap between the number of carers identified through the census and those accessing support. Alongside this, looking ahead, there's an opportunity to begin shaping a more joined-up all-age approach to carers support, including stronger alignment between adult and young carers services, smoother transitions, and a clearer whole-system view of carers' needs. As outlined in the report, there are 4 main areas within the Strategy Action Plan that have not been fully concluded in 2025-26 and require further focus in 26-27. These are work with healthcare providers to deliver awareness-raising training sessions, engaging supporting underrepresented carers in the LGBTQIA+ community, enhancing carer access to assistive technology, and employment-related carer support. While initial work has started across all areas, this will be further driven in year 3. Overall, the direction of travel is towards a more coherent, accessible, and equitable carers offer with clearer routes into support and a stronger focus on early identification and prevention. The report asks to note the progress and the direction of travel as the strategy moves into the next phase. Happy to take questions.
Thank you. Does anyone have any questions? Councillor Begum, then Councillor Hussain.
I do have questions, but Chair, as you are aware, my health is not very well at the moment, so I'm starting to feel unwell. I will email the questions if you don't mind, but if the board won't mind, I did want to say something in AOB. Would it be happy if I just say it? It's a statement I want to make and a request to the Chair and the board. Would it be okay if I do it now? Because I'm starting to get too much in pain, so I need to leave. So
Yeah, okay. Yeah, please go ahead.
thank you. I think, thank you, and I apologize. Across this report, we are seeing consistently in the past scrutiny that there is a pattern. And most of the time, the issue builds up over time and only being picked up, addressed, or picked up once they have reached a serious level. For example, the the maternity and the audiology today. As a scrutiny panel, we need to understand how earlier warning signs are being picked up, and so we don't have to keep reaching to it, reacting top. So warning signs as a panel, how can we do that? So it's a question I'm asking all of my colleagues here to see and think about. Thank you. I will email the questions, and I'm really sorry to interrupt your report. Thank you, Chair.
Thank you. Councillor Hussain?
Yeah, I've got a question and a comment, obviously. The first question, really, the question is, in terms of, unpaid carer, is there a particular crisis support when they are going through difficulty and can contact yourselves?
Yeah, I'm happy to take that question. It's Hannah-Lise, by the way, Head of Commissioning Adult Social Care. Absolutely. So we would have within Adult Social Care really clear kind of respite and crisis support available for anyone in the community who's kind of a carer or has a carer allocated to them. What we're also doing as part of the strategy and in partnership with our new commissioned provider is really aiming to increase the number of emergency plans that carers have in place as well. So sometimes they're called contingency plans or emergency plans, but what we're really pushing forward is ensuring that all carers really know about the importance of having that emergency plan in place, so that in the eventuality something happens to them, there's a really clear record of exactly who should be supported, who would be the next point of contact for their cared for, whether they're a carer who are open to adult social care or whether they're not and they're kind of accessing support in the community. So I was actually just looking through earlier about a new kind of emergency plan template that we have in place through the new provider, which we think will really help so that we have those things in place when there's a crisis emerging, because we know that can be really reassuring for the carer. A lot of stress for carers comes from, what if something happens to me? Who's going to look after my loved one? So we're very much pushing that as part of the strategy moving forward.
More of a comment, Chair. I mean, first of all, valuing unpaid care obviously is a common sense thing, because without them, every local authority will go bankrupt. They wouldn't be able to survive. And I think that they are the most important people. But I'm pleased to see that there is an increasing number of people's awareness in terms of that you've done that in a shorter period of time. Because if they are aware of it, these services, then they can easily access, particularly when they are, and I know particularly in some of the children who are looking after their parents, and they really are the one that ought to be, given a special thing in this term to be able to access those services when they are in real crisis. So I think valuing them as well as the adults, they are doing a fantastic job. And without them, I don't think any local authority, particularly Luton, will survive. Thank you.
Absolutely. Just comment that I'd just like to kind of completely endorse that the more awareness that we raise about carers, people actually identifying as carers, because many people are looking after their family member. It's something that you do for love and for duty, and you won't necessarily identify as a carer. You're just helping your mum, helping your dad, helping your wife. It's a normal part of family life, but helping people to identify that they are carers, and that doesn't necessarily mean that any arrangements will change, but should they need support, should they want more advice and information, that there are people, services out there to support them is really important. So you will have seen in recent weeks through the members' e-brief about the campaign that we're doing to raise awareness, and as that keeps coming through, we would really hope that you will help us to cascade that message to all of your constituents and the residents of Luton. If you can help us, that would be fantastic.
Thank you. I've a few questions. So I think you mentioned about the recommissioning this on April the 1st, and then because you needed a more coherent and focused strategy. So I guess then that sort of implies before it. I mean, is it what has changed to what was it? I mean, I guess there wasn't so much that was it going wrong, or was it the lack of focus and the lack of coherence?
Thank you. I think it was due to be recommissioned anyway. It was the end of the contract period. So in that instance, as we would always do through the commissioning cycle, we're always looking for areas for improvement and strengthening. So I don't think there was anything wrong per se with the previous offer. But what we've very much tried to do is, as you said, kind of refocus it, really think about how we can make that contract fully align with our carers strategy objectives. The previous service was commissioned before we had the carer strategy in place. So we saw a real opportunity to make that contract kind of work harder and align more directly with our strategic objectives through the carer strategy. I think what's also really been enhanced is the how locally embedded we're hoping the new offer will be. Really thinking about how we are maximising our links with the community sector, voluntary sector, and very much reaching out into those spaces where carers may be accessing. So thinking about how we've got a face-to-face presence within family hubs and other areas. We've also, as part of the new contract, got a physical presence at the Luton and Dunstable Hospital, which we think will be really important. Actually, that's obviously where a lot of carers first come into contact with services, is within those kind of health settings. So we do feel that hopefully the spread and the kind of in-reach and outreach into the community is going to be enhanced. The other thing I think is worth noting, as Stephen mentioned, what we have commissioned alongside the face-to-face offer is this supplementary digital offer, which really we're seeing that as a whole kind of package of carer support. They're two separate services, two separate contracts, but we really believe, and through the piloting work that we did, and through speaking to carers, we know that actually there's a lot of carers out there in Luton who can't or won't or prefer to access support within their own home, and particularly outside of traditional 9 to 5 hours. So we feel, as we kind of evidenced in the report, I think that actually having both of these services working together will enable us to give greater choice and control to carers and reach significantly more carers in Luton.
Okay, thank you. Talking about community and all the various places that you're getting the message out to. How about those areas or places where there isn't such a strong community ethos? So if you how would you sort of try and get the message across to individuals or to individual families without necessarily going through community organisations or the hospital or general practices?
Yeah, it's a really good point. So as I mentioned, we have been very much focusing on working with the social justice unit and other groups to kind of get into those communities that we know about. But I guess for those members of Luton who are not kind of actively involved in the community, I suppose it would really be about the kind of outreach work that we're doing, which is very blanket in terms of online social media. We've got a lot through the iCare campaign that's going out through things like Facebook, which, you know, will also, I'm sure, be really widely accessed. But yeah, so I think our social media and our blanket kind of communication across the borough, the posters that we're putting up across the borough featuring the iCare campaign, which will be available for people in the street who are able to kind of who are accessing public spaces. So yeah, I think we've got a kind of multi-layered approach to our engagement. We very much want to go to the communities where they exist, but also through the other steps that I've described about that more blanket kind of media coverage, and yeah, work in the communities will also be kind of hitting other people. But I think it's something we always need to be kind of thinking about and evolving more.
Okay. The question about the numbers, you mentioned that 744 carers engaged in depth support, and I think, did you say that 3/4 of those you'd not noticed before? Is that correct? Am I referring to the right statistic?
Yeah, hi, that's 777 that have accessed the mobilised digital support offer since it launched in October 2025. Yeah, they were unknown to had access to support before.
Okay, so does I guess does that imply that there is quite a large number of carers who out there who need that in-depth support who have not reached yet?
Oh, yeah. So exactly. I think when it comes to carer support, there's different levels, there's different variations. So with the Mobilise website, it might have attracted carers who are just interested in getting a bit more information, a bit more self-service information. The Mobilise website has a whole range of kind of information and guidance. So the way Mobilise works is that, you know, someone who's online and maybe just Googling carer or carer in Luton, it will kind of bring them into the platform, and they'll be able to get that information. So they may be getting information, advice and guidance. They may be accessing peer support groups, etc. So of that 3,000, what we also know is that we have a list of carers who are kind of more known to the council, so formally open to adult social care. And what we're doing through the carers dashboards that Stephen talked about is thinking about how we can match that together, so we actually get a more kind of strategic picture of how many carers are open to adult social care, and how many carers have accessed Mobilise. And also we've had some conversations as well about how many carers, for example, are registered with their GP as a carer, so we can start to build up a far more holistic picture. As you'll appreciate, sometimes the matching between those different data sets can be a bit challenging, but that's something we're looking at the moment. But I think it's also important to note that obviously the census talked about that kind of 16,000 carers. That was a snapshot in time when the census was done in 2021. It would be very unusual for us to know of all of those carers. You know, I think there's different levels of need and support within that.
Okay. Talking about crisis points, previously unpaid carers wait until a crisis point before accessing support. Do you have any idea about whether the strategy as it's been implemented so far, is it having an effect on that sort of issue where carers are waiting till something serious happens before they look for supports?
I don't think at this point we have clear kind of evidence. I think what we're saying through the report is that this is something is part of our strategy, is to get that early engagement and get people accessing the support they need to avoid that kind of crisis engagement point. I think that's something we can certainly look at. I'm just trying to think about how we would evidence that, if you see what I mean, that, you know, when we have that carer breakdown, there would be ways we could understand whether they'd accessed support previously and look to kind of monitor that. But I think we'd have to take a bit more of a look at exactly how we would evidence that. I think what we're saying at the moment is that's one of our strategic objectives through the strategy we've adopted.
Just to add to that, if I might, I think what we've known in the past is that the carers offer in Luton has been fairly limited, in that there is an offer there, and if people contact adult social care, they can get a carer's assessment, and we will do that work. And we've also had the face-to-face support in the old contract, but unfortunately that wasn't necessarily based in Luton and it wasn't embedded in other services. So how many people access that was, I think, limited. We hadn't ever asked them to be because of the old contract conditions, so that, you know, that was just the way that it had been previously designed. And what we're moving to is a much more kind of proactive approach to finding carers, hence the carers campaign. That might be finding them to come forward and have a formal assessment, but it might just be, again, about that self-identification, and then using services like Mobilise. People are getting some benefit support on there as well. They're getting advice and information, going through for a blue badge, you know, for their vehicles, etc. So that is already having a really positive early intervention impact. And that is the route that we're trying to take, is to kind of raise that awareness so we get that earlier identification, and then people can access support and mechanisms more sooner. That isn't to say that people still wouldn't knock on our door when things are at their toughest and it's kind of, you know, reaching more of a crisis point. But we would hope over time, as we do more and more of that early intervention, that less people are feeling that is when they need to contact us, and they might contact us when things are, you know, maybe getting tougher but haven't reached crisis point. But in all honesty, many of those 16,000 carers will not ever need to contact us for formal support. I'm sure we've all got examples amongst our friends and families of doing these roles, and the caring responsibility and role may well end before that anything like that happens and that level of support is needed. But what we want to do is make sure people know that, you know, that there are these different mechanisms should they want them, and there's people to talk to and share how, you know, challenging it can sometimes be and exhausting it can be to be a carer, and have those support networks, and those things are just as important as those formal mechanisms as well.
Yes, well, that's a good point, isn't it? The strategy's got to cater for a wide range of different needs and requirements for those 16,000 people. One last question. One of the aspects that needs work on in year 3 was supporting carers with employment. So presumably that is carers. That's to do with carers who have jobs, and support them in doing those whatever support they need to do those jobs. I mean, is there any support offered for carers who are, say, looking for work? Do you give that sort of career support as well?
Yeah, absolutely. So I think it kind of details within the action plan some of the kind of breakdown of the actions under that area. So what we're talking about within that area is a few different things. Firstly, there's some narrative within the action plan around making Luton Council a really carer-friendly employer. So obviously we have direct control over making sure that happens. We've already had a number of really useful conversations actually about how we really promote that within our own workforce within Luton. So we have really great kind of flexible working policies. We have carers leave available, but there's definitely something about promoting that and making sure that Luton employees are aware of that. We've also had some initial conversations about potentially a carers forum or a staff forum for carers within Luton. So that's kind of one strand of the work. I think there's also something in there about, as the local authority, being able to influence other businesses and other partners within the borough to also adopt kind of carer-friendly working practices, so that we can support more carers in Luton to manage work alongside their caring responsibilities. That last point that you raised about supporting carers to find jobs or kind of remain economically active, that's also really important, and I think something that we'll be, you know, looking at as another strand of the work. I think that really links to the broader strategy actually about carers understanding how they can manage their well-being, how they can access benefits if they're eligible, how they know their rights in terms of accessing carers leave within workplaces, because that is a statutory eligibility criteria that all people in the UK should be able to access statutory carers leave 5 days a year, I think it is. So yeah, I think there's a number of different strands to the work, but yeah, hopefully that kind of summarises some of the key things we're working on. As we said, the reason that's kind of showing as red in the action plan at the moment is that that's where we've started, but we need to kind of drive that forward further in year 3.
Just to say, though, that those flexible working arrangements are in place in the council. We are a good employer. It's more just about that promotion and creating that network. But we already have really strong policies and procedures. But it's just ensuring that everyone understands those and having that network in terms of the council delivery. I think the other thing I'd just like to add to that is that through a range of other pieces of work that we're doing in the council, where we're trying to recruit people into, delivering social care, directly to people of Luton. We are thinking more about kind of, because some people's caring roles is for many, many years. We know it might be a lifelong commitment, but for other people, as we say, it might just be for a few years and that ends, but people can gain quite a lot from that and then might want to think of a role within the profession. And so we will be actively recruiting in the next year for shared lives carers, which is similar to kind of foster care, but for adults that you can do on a part-time short break basis or as a permanent. And it will be, it may be people who've had previous experience of a caring role who might want to be employed to do that. So using those skills and that caring understanding of care needs, etc., that they've gained through their own personal life, that may then lead to some other form of employment within our broad family of adult social care where everyone's welcome.
Yeah, I mean, it certainly strikes me that that sort of experience must be a transferable skill to some extent. The other point I was going to make is you're talking about the red areas. Perhaps red's not the right colour to use because it does look very alarming.
Yeah, fair point. Absolutely.
Okay, if there's nothing, Councillor Ambian.
Thank you, Chair. You have mentioned on the report, page number 22.10, there are 3,400 carers. Can you please confirm these 3,400 carers, are they those working there through the total number of carer who work through the company and freelance, or is it just those who just working as a independent carer, or are they total number of carer who provide support across the borough?
Oh, no, not at all. So these 3,400 carers are unpaid family carers. So they're not employed by anybody. They're not freelance or anything. They're unpaid family members generally, sometimes family friends, but often family members. And these 3,400 are the people who have just contacted this new online service that we've said during October to January. So overall, in the borough of Luton, we think there are around 16,000 unpaid family carers, and this is the number who's contacted this new service that we set up just in October.
Mention about unpaid. So why is unpaid? What is their interest? What is any compensation given to them?
Okay,
to recognize their work?
Yeah, so this whole report is just about the unpaid carers. So this is about adult social care and all of us. And, if our loved one, you may do it yourself for your family and not even think that this is a caring role. So if you need to take maybe your mum or your dad or your brother to hospital, make sure they've got their shopping in because they're not capable of doing those kind of things themselves. You are technically an unpaid carer, family carer. And this report is all about how we recognise and identify those carers and support them, not by way of financial compensation, but much more in terms of making sure that they've got the emotional support that they need and the practical support that they might need to improve their lives and do other things. For some of those individuals, a very small number who take under extensive caring roles, so perhaps being 24-hour care and support roles, their loved ones might also get a statutory care package from us to support them, so they're not doing all of that themselves. It's a mixed response, and we may also give that carer a carer's grant so that they can do something that is going to be important to them away from their family member, because they might also not be able to work if they were caring to that extreme level. But there's a whole continuum of people who are delivering very intensive support to those who are providing a little bit of support. And as I say, sometimes that's lifelong and sometimes that's for a few years.
Thank you. Yeah, actually, totally. This is the first time I heard. It's new. As a working people, sometimes we have to compromise our work-life balance. Sometimes difficult. So it will be very much useful if you can disseminate the information to the general public. So people, of course, each household there are unrecognized carer there, but it will be helpful, useful. Maybe if the information is available, if there is support. You just mentioned about grant or one of things. So working people, they can maybe claim because now it's cost of living and unemployment is very challenge. Like unemployment is high and people are very worried about to maintain their work-life balance and keep employment, to maintain the family life and employment life balance is find difficult. So if there any support grant can be available and information is available to the public, it will be benefited in general.
So we're doing that through our campaign, our awareness campaign, and through our website. People will be able to see the type of support that they're available to. And to make it clear, though, Councillor, that if you are a working carer, it would probably be unlikely that you would be eligible for any financial support. But it is there for those who are in the most needy situation. That you have to complete a statutory eligibility assessment for that. But we offer much broader support, which many people will find very helpful for them. Absolutely.
Thank you. If that's it. Thanks for coming along tonight and presenting. I think we're asked to note the recommendations on the page 1 of the report. I think we can do that. Thank you very much. Brings us on to the last item on the agenda, which is the draft work programme. And as usual, we're asked to approve the work programme and determine whether to include, etc., items from the executive or the Health and Wellbeing Board, and delegate responsibility to changes to the work programme to the Democracy and Scrutiny Officer, etc., etc. I think we can do that. That's it. Thank you very much.
So, well, that's 8 o'clock on the